Welcome everybody to the presentation titled Antibiotics and What They Treat, sorry. My name is Pranita. I'm an associate professor of pediatrics in the Division of Infectious Diseases at Johns Hopkins Hospital. And I also serve as the director of the Pediatric Antimicrobial Stewardship Program. I see patients in the hospital, in clinic, and over telemedicine. And I'm one of the leaders of this antibiotic stewardship program, along with my colleagues at NORC at the University of Chicago and Johns Hopkins University. And should you have additional questions after this webinar, please note the safety program's email address on the slide. And some of you are coming from practices where you see patients in person and some patients virtually, and others of you are coming from practices where you see all patients virtually, and hopefully the content from this webinar will be helpful for all of you. There's a few administrative slides before we start the presentation. None of the presenters have any conflicts of interest relevant to the program. The faculty and the planners or managers for the Postgraduate Institute for Medicine, Johns Hopkins University, AHRQ, and NORC also have nothing to disclose. And in support of improving patient care, this activity has been planned and implemented by the Postgraduate Institute for Medicine and National Opinion Research Center. Postgraduate Institute for Medicine is jointly accredited from the different groups that are mentioned on the slide to provide continuing education for the healthcare team. And for physician continuing medical education, this live activity is designated as one credit. For continuing nursing education, the maximum number of hours awarded is 1 contact hour, and it's designated 1 IPCE credit. And successful completion of the CME activity, which includes participation in the evaluation component, enables the participant to earn up to 1 medical knowledge MOC point, up to 1 practice assessment MOC point in the American Board of Internal Medicine's MOC program, and up to 1 MOC point in the American Board of Pediatrics MOC program. Okay, so thanks for bearing with me through all of that. At the end of this presentation, participants will be able to describe the spectrum of activity of commonly prescribed antibiotics used in children and adults in the telemedicine setting, describe common antibiotic-associated adverse events in children and adults, and common indications for oral antibiotics in children and adults in the telemedicine setting. And this presentation is meant to provide an overview of antibiotics. About 30 to 40% of patients in the telemedicine setting receive antibiotics, which really underscores the importance of understanding appropriate antibiotic use during virtual visits. And in other future webinars in the HRQ safety program, Sarah Keller and I will be providing more details on the use of these agents for common outpatient indications. But for this presentation, we're really just focusing on spectrum of activity, adverse events, and we generally will be using generic names and not brand names. Okay, so just very briefly, let's start by discussing beta-lactam antibiotics. When we say beta-lactams, we're including 4 classes of drugs: penicillins, cephalosporins, aztreonam, and carbapenems. And we'll be reviewing antibiotics within the beta-lactam classes that are commonly prescribed in the outpatient setting. So as a brief overview on how these agents work, both gram-positive and gram-negative bacteria have cell walls. And these cell walls are made of peptidoglycan chains that are cross-linked by enzymes called penicillin binding proteins. So I kind of think of the peptidoglycan chains as sort of beams in keeping a building together. And maybe the penicillin binding proteins are sort of the nails and the things that keep the beams connected to each other. So beta-lactam antibiotics work by interfering with the function of penicillin binding proteins. So they basically mimic the structure, insert themselves, and cause the bacteria to fall apart and die. So atypical bacteria like Mycoplasma pneumonia, Chlamydia pneumonia, Legionella pneumophila do not have cell walls, and therefore beta-lactams will never work for these organisms. So you'll never find that amoxicillin or cephalexin will be active against, for example, mycoplasma. And common adverse events to think about with beta-lactams in general are rashes and diarrhea. Rashes are generally maculopapular, resolve after antibiotic discontinuation. There are, of course, some more concerning rashes like hives. And in a future webinar, we'll discuss antibiotic-specific allergies and how to circumvent these issues. Similarly, diarrhea is generally mild when it's associated with beta-lactams, but patients should be cautioned that this is a potential side effect. And obviously, for specific types of diarrhea like C. difficile infections, which can be quite concerning, the signs and symptoms that would warrant a return to medical attention should be discussed. Now, fortunately, for some of the adverse events we think about with intravenous beta-lactams like cytopenias and seizures, these tend to be very uncommon with oral beta-lactam agents. So let's start by discussing the first class of oral beta-lactams, the penicillins. There are oral, intramuscular, and intravenous formulations of penicillin. The oral formulation of penicillin is very poorly absorbed. So this is PenVK, and therefore it's not commonly used for the treatment of active infections. So penicillins cover gram-positive bacteria such as group A strep, group B strep, Streptococcus pneumonia. But if you're thinking of oral therapy, for example, a group A strep cellulitis or strep pharyngitis, we often think about alternate beta-lactams like amoxicillin, or even a first-generation cephalosporin, for example, for a cellulitis, because the absorption of oral penicillin is just not very good. Intramuscular penicillin G-benzathine is the preferred treatment for early and latent syphilis. We'll discuss this in future webinars focusing on sexually transmitted infections, but for those of you who practice in the clinic setting where you see some patients in person, this is an important penicillin to know about. Okay, let's talk about amoxicillin. Amoxicillin belongs to a class of penicillins called the aminopenicillins. The other member of this class is ampicillin, which is administered generally intravenously. So amoxicillin and ampicillin cover the same gram-positive organisms as penicillin, and in addition, amoxicillin is considered a preferred treatment for Enterococcus faecalis. Amoxicillin has broader gram-negative coverage compared to penicillin. So amoxicillin can cover respiratory gram-negative bacteria like Haemophilus influenza, but about 25 to 30% of H. flu isolates produce a beta-lactamase enzyme, and this enzyme can basically hydrolyze amoxicillin, which is a beta-lactam, so it can inactivate it. But fortunately, when you add clavulanic acid to amoxicillin, commonly known as augmentin, augmentin can treat isolates that produce these beta-lactamase enzymes. So when you see a lab report, you might see Haemophilus influenza. If there's no more data on susceptibility, the safest bet is amoxiclav or augmentin. If it says not beta-lactamase producing, or if it actually just says ampicillin susceptible, then you know amoxicillin will be just fine. But if it says it produces a beta-lactamase or it says resistant to ampicillin, then you would know that you would need to use a drug like amoxiclav. And most labs don't usually test specifically for amoxicillin. They would test susceptibility to ampicillin. So amoxicillin can be used, is also highly effective for the treatment of enteric gram-negative bacteria like E. coli, but unfortunately, more than half of E. coli in the United States produce a beta-lactamase that inactivates amoxicillin. So as E. coli are the most common cause of urinary tract infections, I would not suggest amoxicillin as empiric treatment for UTI. So what this means is that if you see the lab report, it says E. coli, you don't have susceptibilities back, or it's a healthy young woman with symptoms of what sound like a UTI, most likely E. coli is the culprit. I wouldn't suggest using amoxicillin without susceptibility data that tells you amoxicillin is actually going to be active against the E. coli, because there's a very good chance it won't be. But if you see the susceptibility report and it says E. coli ampicillin susceptible, then you certainly could use amoxicillin, depending on the clinical context. And we'll talk more about urinary tract infections and the treatment options, including specific antibiotics, duration of treatment, et cetera, in a future presentation. Enterococcus fecalis is another common cause of UTIs. It's basically 100% susceptible to amoxicillin. So if you know that a patient has a cystitis, for example, you see that it's Enterococcus fecalis that's growing, even if you don't have susceptibility results back yet, you can feel assured that amoxicillin will be active. So there's several common indications for which amoxicillin can be considered in the telemedicine setting. This includes group A streptococcus pharyngitis. Amoxicillin is always active against group A strep. Resistance has never been reported. So even if you don't have susceptibility testing results, which you generally never would for group A strep pharyngitis, you could feel confident that amoxicillin will be active. Amoxicillin can also be considered for skin and soft tissue infections, but only if you know that group A strep is present. So a lot of times when we see non-suppurative cellulitis, so there's not pus forming, it's generally caused by group A strep or MSSA. Unfortunately, amoxicillin will not cover MSSA, but it will cover group A strep. So I would only suggest amoxicillin for a skin and soft tissue infection if you have confirmation group A strep is present. Amoxicillin is a preferred treatment for community-acquired pneumonia in children and adults, as well as acute otitis media, because these are generally caused by Streptococcus pneumonia, which overwhelmingly should be susceptible to amoxicillin. And generally, and we'll discuss this in future webinars, at least for children, we would prescribe higher dosages of amoxicillin for these indications. Amoxicillin can also be used for urinary tract infections, as I already mentioned. If E. fecalis, Enterococcus fecalis, is recovered even without susceptibility results, but again, only for E. coli if you know that the E. coli causing the UTI is susceptible to amoxicillin. And finally, amoxicillin is a preferred treatment for children with Lyme disease, adults who have issues tolerating doxycyclin for Lyme disease. Future syndrome-specific webinars in the HRQ safety program will discuss the use of amoxicillin for specific infectious conditions in much more detail. And unfortunately for this current webinar, it'll probably take the full hour, so we probably will not have time for questions, but there definitely will be an office hour coming up next week where we could devote the whole hour to questions about antibiotics, so we can go into more detail about some of the experiences you have had. So let's move on to amoxicillin clavulanic acid. Clavulanic acid broadens the coverage of amoxicillin to also include coverage of methicillin-susceptible Staph aureus. So 100% of MSSA is susceptible to amoxicillin clavulanic acid. So you never have to worry. If you see MSSA, you know amoxiclav will be effective. Obviously, there's some nuances to that. If you're treating a bacteremia or something more invasive, again, it's unlikely in the virtual setting. But we'll talk more about the specifics of this, of indications for amoxiclav in future webinars. But with the addition of clavulanic acid, the good news is that along with MSSA and some more gram-negative organisms, the indications for when amoxiclav can be used over amoxicillin are broadened. So with the addition of clavulanic acid, as I mentioned on the last slide, all Haemophilus influenza isolates are covered. There's another bacteria that sometimes lives in the respiratory tract called Moraxella catarrhalis. 100% of Moraxella catarrhalis are susceptible to amoxiclav, which again is also known as augmentin. So whether these and bacteria, Haemophilus influenza or Moraxella, are producing a beta-lactamase enzyme or not, it doesn't matter. Amoxicillin clavulanic acid will be effective. Also, as I mentioned, amoxiclav, similar to amox, will cover Streptococcus pneumonia. So amoxiclav is commonly used for infections like sinusitis, community-acquired pneumonia, chronic obstructive pulmonary disease exacerbations, because again, these are generally caused by bacteria like strep pneumo, Haemophilus, maybe Moraxella, and you can feel confident that amoxicillin clavulanic acid will provide adequate coverage for these infectious processes. Amoxiclav can also be considered for the treatment of acute otitis media in children who recently received amoxicillin or with a history of recurrent otitis media unresponsive to amoxicillin, because again, amoxicillin does not cover large percentages of Haemophilus influenza, which might be the culprit causing the child to fail therapy with amoxicillin. So we'll discuss respiratory infections like community-acquired pneumonia, sinusitis, COPD, otitis media in future webinars. For E. coli, however, clavulanic acid broadens the coverage of amoxicillin to cover only about 50% of E. coli. So therefore, amoxiclav, just like amoxicillin, can only be used for E. coli UTIs after you have susceptibility data back to indicate susceptibility. So I shouldn't say it can only be used, but that would be the suggestion I have, that you confirm that it's actually susceptible before prescribing this agent. And although newer data indicate that moderate diverticulitis may not require any antibiotic therapy, for select patients with diverticulitis, if the decision is made to prescribe antibiotics, amoxicillin clavulanic acid remains an option. And finally, amoxiclav is a preferred treatment for skin and soft tissue infections from animal bites, which we'll be discussing in a future webinar. The one thing I just want to stress with amoxiclav, even though I said all beta-lactams can cause diarrhea, it's often much more notable with amoxiclav, particularly when higher dosages are used. In general, we expect that about 1 in 5 patients who receive amoxicillin clavulanic acid will have diarrhea. So we usually would suggest counseling patients ahead of time and letting them know when it's reasonable to be managed at home and when the diarrhea, abdominal pain is more concerning, that would prompt an in-person visit for the patient to be evaluated. Okay, we'll move on to the cephalosporins now. There are 2 commonly prescribed oral first-generation cephalosporins, cephalexin and cefadroxil. So these are 2 oral first-generation cephalosporins available in the United States. Cephalexin is commonly called Keflex, and cefadroxil Duracef. They have identical spectrums of activity, so in the outpatient setting, I would say you can use them interchangeably. The one thing to note is cephalexin has to be given 3 to 4 times a day versus cefadroxil twice a day. So it's, of course, much more convenient, but sometimes patients have trouble accessing cefadroxil. It's not always available in pharmacies, but otherwise, both of these are interchangeable. Although recent data indicate that cefazolin, so the IV formulation commonly called Ancef, is safe to give to patients with severe penicillin allergies such as anaphylaxis or hives, I just want to stress that this doesn't seem to be the case with oral cephalosporins. So what this means is that if you have a patient with severe penicillin allergy, recent data and recent guidelines say if they're hospitalized and you're considering cefazolin, it's fine to use. We don't expect there to be cross-reactivity. But it's important to note that if they do have severe penicillin allergies, you're in the telemedicine setting, I would not suggest administering cephalexin or cefadroxil because there's about a 5% chance of cross-reactivity. So cephalexin and cefadroxil, I think, are great choices for skin and soft tissue infections when you're not concerned about MRSA. So maybe the patient has never had a history of MRSA, they don't sound very ill, you're not in a setting where there's just a lot of MRSA. The reason I say these are great is they cover a group A strep, group B strep, so a lot of the strep species that cause skin and soft tissue infection, they also have excellent coverage against MSSA. So 100% of MSSA isolates will be susceptible to cephalexin or cefadroxil. Additionally, these drugs have broader coverage against gram-negatives compared to amox and amoxiclav. So you can also think of them for the treatment of UTIs caused by bacteria like E. coli, Klebsiella pneumonia. So again, we'll talk more about this when we discuss UTIs, But in my opinion, because cephalexin has such broad coverage against E. coli club pneumo, in otherwise healthy patients with cystitis, where you may not have susceptibility data back yet, cephalexin can be used, cefadroxil or cefadroxil, as potentially empiric coverage because they have a high likelihood of activity against E. coli Klebsiella that cause UTIs. Okay, we'll talk about cefuroxime. This will be the only second generation cephalosporin we discuss because the other ones are only available intravenously and used inpatient. So cefuroxime is a second generation cephalosporin. It can be it has both IV and oral formulations. It has activity against both gram-positive and gram-negative organisms that cause respiratory infections like sinusitis, community-acquired pneumonia, COPD exacerbations, and acute otitis media. So I think that this is a really nice oral option for respiratory infections. I would say that similar to amoxicillin clav or augmentin, cefuroxime is another oral drug that provides broad coverage against bacterial respiratory infections. In terms of third-generation cephalosporins, some notable third-generation cephalosporins that are administered in the outpatient setting are intramuscular ceftriaxone. Of course, this is only relevant if you're seeing outpatients in person, and a variety of oral cephalosporins is listed here. Cefdinir, commonly called Omnicef, cefpodoxime, commonly called Vantin, cefixime, commonly called Suprax. So these are common oral third-generation cephalosporins. So for IM ceftriaxone, it's commonly administered for the treatment of gonorrhea, as we'll discuss in a future webinar, and sexually transmitted infections. Third-generation cephalosporins have broad gram-positive, gram-negative coverage, but something I really want to stress is that it's important to note that ceftriaxone covers basically all Streptococcus pneumonia, but that's not the case with oral third-generation cephalosporins. So for cefpodoxime, cefixime, cefdinir, just because a strep pneumo isolate is susceptible to ceftriaxone, we don't know if that's always the case with these oral third-generation cephalosporins. So what that means to me is that if you're concerned a patient might have community-acquired pneumonia, sinusitis, some kind of bacterial respiratory infection, as I mentioned, augmentin or amoxiclav is a great choice. Cefuroxime is a great choice, but I wouldn't suggest considering these oral third-generation cephalosporins the same way because there's a decent chance they may not cover Streptococcus pneumonia. I will say that and the exception, of course, is if someone has severe penicillin allergies and you're less limited in your options. But we can talk about that in a future webinar when we discuss these respiratory infections in more detail. The good news is that for Enterobacterales, so for example, an E. coli, if, for example, it's susceptible to ceftriaxone, resistance to a first-generation cephalosporin, so you don't now think Keflex is a good choice, if the isolate, the Enterobacterales, so like E. coli, Klebsiella pneumonia, that's what we mean by Enterobacterales, was susceptible to ceftriaxone, there's a very high likelihood that an oral third-generation cephalosporin will be active. So even without targeted susceptibility data. So in my opinion, for oral third-generation cephalosporins, I think the indication that you'll most commonly consider them for is urinary tract infections, I'd say, specifically when first-generation cephalosporins are not active. Okay, so we'll move on to the fluoroquinolones. There's 4 oral fluoroquinolones: ciprofloxacin, levofloxacin, moxifloxacin, and delafloxacin. Ciprofloxacin has broad gram-negative coverage, including coverage of Pseudomonas aeruginosa, and it's commonly prescribed for urinary tract infections. And it's very effective. When it's susceptible, when an isolate's susceptible to ciprofloxacin, it's very effective for this indication. Levofloxacin has basically the same gram-negative coverage as ciprofloxacin, so also pseudomonal coverage, but the added bonus is that it also covers Streptococcus pneumonia. So levofloxacin is also like ciprofloxacin commonly prescribed for UTIs, but it can also be considered for bacterial respiratory tract infections, especially for patients with severe penicillin allergies. So as I mentioned in the last couple of slides, if you have a COPD exacerbation, potential community-acquired pneumonia, sinusitis, ear infection, where you normally might have prescribed augmentin, but there is a severe penicillin allergy. If you're nervous about using third generation oral cephalosporins and also understanding that there will be some drop in the strep pneumo activity of these agents, and we can discuss, again, we will be discussing penicillin allergies in a future webinar. You might want to think about a drug like a levofloxacin. You won't see cross-reactivity in terms of allergy issues, but it will cover the respiratory bacteria that cause these infections. And so will moxifloxacin. So moxifloxacin, also like levo, is a great choice for respiratory bacterial infections in the setting usually of penicillin allergies. But moxifloxacin, unlike Cipro and Levo, does not cover Pseudomonas. So I wouldn't suggest it for a UTI, for example. It also doesn't concentrate as well in the urine. So finally, delafloxacin is the newest fluoroquinolone. It has similar activity as moxifloxacin, but it also covers MSSA, MRSA. So I think of delafloxacin as moxi, so respiratory coverage, with the addition of MSSA and MRSA, which is quite nice. So it's might be considered for the treatment of skin and soft tissue infections when you're considering Staph aureus. If for some reason all the usual beta-lactams you would think about, like a first-generation cephalosporin, is not an option for MSSA, or you don't know if there's MRSA or MSSA involved, and you don't want to put them on multiple drugs, delafloxacin might be a good choice. And similarly for bacterial respiratory infections, because it provides coverage against the typical bacteria we think about, as well as MSSA and MRSA, it might be a nice option in the rare patient where they have a more complicated pneumonia, they're being discharged to continue on oral therapy, and there's a problem with other available oral options that you might think about for respiratory infections. So we can discuss this in depth in future webinars that are more syndrome specific, but I think something very important to address with the fluoroquinolones is the side effect profile. The adverse event profile with quinolones is notable. I always advise discussing these with patients when they're prescribed. These include increased risk of Clostridioides difficile infections, much higher than other classes of antibiotics. In one study, about 13 times higher than other classes of antibiotics. It can prolong the QT interval, which is generally most problematic in patients with other risk factors, such as underlying arrhythmias, or patients receiving other QT prolonging drugs like azithromycin or fluconazole. The fluoroquinolones can cause tendinitis or very rarely tendon rupture. So I always counsel patients on where tendons are located, if they're starting to feel pain in that area, to stop the antibiotic and call a healthcare provider. And they can also cause CNS toxicities like dizziness, confusion, hallucinations. So it's good to warn patients about this, especially elderly patients who are more susceptible to these side effects. And the one thing I just forgot to mention with the fluoroquinolones is that they chelate cations like calcium, magnesium. So this can reduce their bioavailability if you're administering them with a multivitamin or yogurt or milk. So I always counsel patients to either to space these out, to space out when you're getting the ciprofloxacin and when you're taking yogurt, or for things like multivitamins to just consider holding them while you're on a quinolone, especially if it's a reasonably short course, which hopefully it should be most of the time. Okay, so next we'll talk about doxycyclin. Doxycyclin has a broad spectrum of activity. It covers gram-positive bacteria like MRSA. It's active against almost 90% of Streptococcus pneumonia, about 80% of group A strep, So pretty broad gram-positive coverage, including strep and staph, including MRSA. Doxycycline also covers respiratory gram-negative bacteria and a number of enteric gram-positive bacteria as well, as you could see listed on the slide here. It's important to note that doxycycline has very limited urinary excretion, so we would not suggest it for the treatment of a urinary tract infection. So unfortunately, if you have an E. coli and you see an S for susceptible next to tetracycline, because you could use that susceptibility interchangeably for doxycycline, we would not advise doxycycline for a UTI. The good news for those of you who take care of children is that newer guidance, including data from the American Academy of Pediatrics, indicate that doxycycline is safe to administer in children of all ages, even children under 8 years of age, for durations of 21 days or less. There's been no reports of any kind of permanent enamel damage with doxycycline in children. We unfortunately don't have data beyond 21 days to say whether or not it's safe beyond 21 days. But at least for 21 days or less, there's quite a bit of data that underscore that doxycycline is a good option to consider as a treatment choice. And similar to fluoroquinolones, doxycycline chelates cations, so their bioavailability is significantly reduced when administered with calcium, iron, antacids, multivitamins, milk, or yogurt. So again, just like the quinolones, you might want to think about spacing the drug from these other foods and medications out, or if you can, temporarily discontinuing these medications. So in terms of what I always tell patients with doxycycline, it can cause gastrointestinal upset. So it's generally advised they take it with a small meal. Again, I would avoid yogurt and maybe a fruit or some other kind of snack instead. It can cause photosensitivity, so we always suggest not avoiding direct sunlight, sunscreen, long sleeves, wearing a hat. There's some patients who've been on doxycycline for several weeks where we actually see, as part of the photosensitivity, they lose their nails. Unfortunately, they seem to regrow. Doxycycline, and I suspect that's because they may have washed their hands, so they're not having sun protection on their hands when they're out in the sun. Doxycycline can cause increased intracranial pressure. This seems to be most problematic in females who are overweight. So I always advise them, if they're having headaches or developing double vision, to let a healthcare provider know right away. Additionally, doxycycline specifically can cause something called pill esophagitis, which are esophageal ulcers. So I would always suggest for the evening dose, because people generally take doxycycline twice a day, that they take it with a glass of water or some kind of liquid, and they sit up after they take it, ideally for about 30 minutes, just so that the pill makes its way to the lower intestinal tract. And then common outpatient indications for doxycycline include skin and soft tissue infections, because again, it covers group A strep, MSSA, MRSA, osteoarticular infections where these same bacteria can be problems, bacterial respiratory tract infections because it covers strep pneumo and H. flu and the types of bacteria that typically cause respiratory bacterial infections. And then for tick-borne illnesses, if you live in a part of the country where Rocky Mountain spotted fever is a problem, or lichiosis, definitely if somebody, again, this is less probably as relevant for the ambulatory, for the telemedicine setting, but certainly if you're seeing patients as an outpatient where you're worried about Lyme disease and so forth, doxycycline is a great choice. It also is a consideration for someone who is in a Lyme endemic area who was bitten by a tick as prophylaxis, a single dose doxycycline. It's also used for the prevention treatment of malaria, and it's a preferred treatment for chlamydia, which we'll discuss in a future webinar. So it's kind of my favorite antibiotic because it covers all sorts of things, and the toxicities are usually not as bad as some of the other antibiotics. Okay, for clindamycin, it's an option for skin and soft tissue infections when MRSA is a concern. And it covers MSSA as well. It's just that there are, I think, in my mind, more effective options with less toxicities, like cephalexin, for example. are cefadroxil, first generation oral cephalosporins. The problem for Clinda, there's two main problems, one of which is growing resistance. So specifically, there's some regional variation, but in the United States, there's data from some regions that clindamycin is active against only about 60% of MRSA isolates and only about 60% of MSSA isolates as well. So obviously, this is probably not your first choice for MSSA, but if you're not sure, if you're worried about staph and you don't know MRSA or MSSA, or more importantly, you don't have susceptibility data back, it's important to know there is a reasonable risk that the isolate will not be susceptible to clindamycin, maybe as high as a 40% risk. The CDC reports that about 20% of group A strep isolates, which again is another common cause of skin and soft tissue infections, are resistant to clindamycin. So the one issue with clindamycin is we are seeing growing resistance in the United States for common gram-positive bacteria. The second concern, of course, is the association it has with C. difficile infections. Just like the risk is actually not as high as the fluoroquinolones, but just like the fluoroquinolones, I definitely let patients know that if they start to have significant abdominal pain, diarrhea it's not just loose stools, but it's really just multiple times a day, liquidy, or they're starting to have new fevers, that they definitely should contact a healthcare provider right away, because there is a chance that they have C. difficile infection, Okay, let's move on to trimsulfa. Trimethoprim sulfamethoxazole is commonly referred to as Bactrim or Septra. Trimsulfa frequently covers, it's frequently prescribed for skin and soft tissue infections since it covers MSSA, MRSA, strep pyogenes. There's actually, I think, very good news more recently that indicate that trimsulfa actually covers over 95% of group A strep isolates. When I was in medical school, and for a lot of us, when we were in training, we had learned that you can't use trimsulfa for group A strep. If you're using it for a skin and soft tissue infection, you don't know the bacteria, you might want to add cephalexin or amoxicillin to it. But the good news is the vast majority of group A strep isolates are susceptible to trimsulfa. So if you have, let's say, a suppurative skin and soft tissue infection, there's pus there, you're worried about MRSA, but there might be MSSA, there might be group A strep, that you could feel pretty good that trimsulfa will be a good option to cover all of these organisms. Trimsulfa is also commonly used for urinary tract infections, as we'll discuss in a future webinar, but unfortunately, resistance to this agent is growing. So I would say that for like a cystitis, it's probably just fine to use upfront empirically. If someone has a pyelonephritis, you could use it, but you just want to be a little cautious. This means a UTI, maybe they have a fever, but they're not sick enough to be hospitalized. You can think about it, but there is this concern that there will be resistance, and it's probably better to have treatment guided by urine culture results. So again, we'll discuss that in the future. The really important thing to think about with trimsulfa is to warn patients about adverse events. In the inpatient setting with IV trimsulfa, there's all sorts of adverse events we think about in the outpatient setting as well, especially with prolonged durations. But some things to think about are hypersensitivity reactions. These can range from a mild maculopapular rash that still can be very itchy and bothersome for patients to severe infections like Stevens-Johnson syndrome. There's other things like hepatitis. If someone's on trimsulfa, they're starting to get new fevers, abdominal pain, nausea, vomiting. There's a lot of side effects from trimsulfa that I definitely say to patients, I give them a list of rashes, nausea, vomiting, abdominal pain, new fevers. If any of these things happen, reach out to your healthcare provider. Because some of these really do progress to conditions that require hospitalization. And I usually tell them to stop the medicine and call the healthcare provider for further guidance. So Lenalid is an antibiotic with broad gram-positive coverage. It does not cover gram-negatives at all, but the gram-positives it covers quite impressive: MSSA, MRSA, Enterococcus, including vancomycin-resistant Enterococcus, which isn't a common problem for most outpatients. But occasionally, if you have a patient, for example, with prone to complicated UTIs, maybe they're catheter dependent, this is a bacteria that might be a problem. And fortunately, VRE is really the only oral antibiotic that's active against this bacteria. It also covers pneumococcus, including so this means streptococcus pneumonia. It's most commonly prescribed for skin and soft tissue infections in the outpatient setting. So if you have someone where you're not sure, is it MRSA, is it MSSA, is it group A strep, and you don't have susceptibilities back, but there's toxicities or adverse events that precludes a lot of the other drugs I spoke about, linezolid is a good choice. If you have a MRSA isolate where there's maybe resistance or toxicities with all other options, I might think about linezolid at this point. Linezolid, I think, is a very good drug for gram-positives, but I try to preserve it for when there's no other options, simply because this is the broadest gram-positive oral drug that we have. And I hate to develop too much resistance to it, which would make it challenging to use clinically. In terms of adverse events, it does have a bothersome profile, but the good news is that for short courses, which is what you probably will mostly prescribing in the telemedicine setting, 5 days, 7 days tops, the likelihood of adverse events is quite low. The adverse events we see are bone marrow suppression, particularly thrombocytopenia. It tends to occur after 2 weeks of therapy, so I generally don't obtain CBCs for outpatients with linezolid unless they're going to be on it beyond 2 weeks. And then, unfortunately, it can cause neuropathies, peripheral optic neuropathies. These can present in this glove and stocking distribution or diminished visual acuity. They may not always be reversible, so this can be concerning. But luckily, they seem to happen after patients are on linezolid for many months. It's more of a cumulative toxicity and not for patients who are on it for just 5 or 7 days. Lactic acidosis is very rare, but it has high mortality. It generally only occurs in patients taking more than a month of linezolid. The way lactic acidosis presents is patients have abdominal pain, nausea, vomiting, generalized weakness. I usually counsel patients if they're starting to have nausea, vomiting with the linezolid to stop the medication and call their healthcare provider. And finally, linezolid can cause serotonin syndrome when it's taken with an SSRI. Even though serotonin syndrome occurs in less than 5% of patients taking both medications, so both linezolid and an SSRI, I always advise patients in the outpatient setting to just hold off to see if they can hold off on taking the SSRI while completing the linezolid course. That's my preference. There's some data saying it may be safe to continue the SSRI, but I think that since these patients are in the outpatient setting, this is a telemedicine visit where you aren't going to be monitoring them actively the way you might in an inpatient setting, for example. I would advise that you suggest they talk to whoever prescribed the SSRI to see if they can hold off on taking it while completing the linezolid course. And if they can't, thinking about an alternative antibiotic. The symptoms to think about to trigger in your head serotonin syndrome are tachycardia, hyperthermia, agitation, tremor. Usually the most common thing is this tremor. So if a patient is on linezolid, they're starting to have a tremor, I would tell them to, if they were still on something that's a serotonin SSRI type agent, this is a sign that they might have serotonin syndrome and should stop taking the linezolid. So because all the toxicities with linezolid really start to manifest after a month, except for the thrombocytopenia, which could be after 2 weeks, I really try not to prescribe linezolid beyond a month unless I have absolutely no choice. And that's usually for some other infections like mycobacterial infections, which are not things you'll be managing in the telemedicine setting. But when we talk about skin and soft tissue infections and linezolid, we'll sort of reiterate that for most of these infections, the treatment course is about 5 to 10 days. Okay, we just have a few more drugs I think we could finish by the end of the hour. As I mentioned, unfortunately, we probably have to save questions for office hours. So azithromycin is commonly considered for mild bacterial respiratory tract infections like community-acquired pneumonia, especially when severe penicillin allergies preclude the use of a beta-lactam. Azithromycin generally provides coverage against Streptococcus pneumonia about 70% of the time, so it's not going to be as high as amoxicillin or amoxiclav, but azithromycin also provides coverage against respiratory gram-negative bacteria like Haemophilus and atypical bacteria like Mycoplasma pneumonia. I will say, because there is an upsurge of Mycoplasma pneumonia cases in the US right now, most Mycoplasma pneumonia is susceptible to Zithro. In the East Coast, there's emerging data that about 20% of Mycoplasma pneumonia isolates are not susceptible to azithromycin. However, these isolates do remain susceptible to doxycyclin. So if you're taking care of a patient who has what seems to be Mycoplasma pneumonia, or somehow the diagnosis was confirmed, and they don't seem to be improving with azithromycin, you might want to think about a short course like 5 days of doxycyclin. So other common outpatient indications for azithromycin include a single 1 gram dose of chlamydia for people unlikely to adhere to a 7-day course of doxy, or for pregnant people with chlamydia, and as well as for travelers' diarrhea. And all of these will be discussed in future webinars. An important point with azithromycin is in 2021, the FDA issued a warning about an increased risk of acute cardiovascular death among people taking azithromycin in observational studies. And one study showed this increased risk of acute cardiovascular mortality with azithromycin when compared to a drug where we don't expect that toxicity, like amoxicillin. I will note that causality has not been established, but what most of us would suggest is if you have patients who are receiving other QTc prolonging drugs, you probably want to avoid azithromycin if you can, unless you're really limiting it to a very short course. And definitely if you have patients with known cardiovascular disease, like known arrhythmias, I would try to avoid azithromycin if at all possible. Okay, nitrofurantoin, really the only time you should think about this drug is for uncomplicated cystitis in women. The macrobid formulation is the drug commonly prescribed. It's taken twice a day for 5 days for cystitis, as we'll discuss in a future webinar. Nitrofurantoin has good coverage against E. coli and other gram-negative enterics that commonly cause UTI. So even if you don't have susceptibility data back, you have someone you're seeing over telemedicine with dysuria, urgency, frequency, and otherwise healthy female, you're thinking cystitis, you could feel pretty good about prescribing nitrofurantoin. It should cover most E. coli and other gram-negative bacteria that cause UTIs. I would suggest avoiding it if you're worried about pyelonephritis. So if the patient has fevers or back pain, specifically like flank pain, where you're thinking that there might be pyelonephritis because this drug just doesn't concentrate in the kidneys very well. And in patients with significant renal dysfunction, there may be insufficient accumulation of nitrofurantoin in the urine. So it's often not suggested if someone has chronic kidney disease, if there are other options available. And otherwise, if there's not, I would suggest using it. The main adverse events we tell patients with nitrofurantoin are pneumonitis. It could be an acute pneumonitis. It's rare, 1 in 5,000 patients. It usually occurs after a week of therapy. And since cystitis should really only be treated for 5 days, I think that if you're limiting your treatment durations for nitrofurantoin, this shouldn't be a problem. It generally presents with cough, fever, dyspnea. It is reversible after the drug is discontinued. It could take several weeks to recover, for the patient to recover. Chronic pulmonary fibrosis is much more ambiguous to me. It usually occurs after prolonged nitrofurantoin therapy. The recovery of lung function, though, is much more limited. It occurs over months to years. So sometimes it's hard to say if someone has chronic pulmonary fibrosis, is this idiopathic, or might this have been related to some nitrofurantoin course they received months or even years ago? Unfortunately, this, if I didn't mention, may not be reversible. And the last two drugs, Phosphoomycin is just like nitrofurantoin, cystitis only drug for the most part. It doesn't concentrate well in the kidneys. The nice thing, it can be given as a single oral dose for cystitis. There is emerging data that maybe multiple doses might improve outcomes. So we'll discuss this in more depth in the UTI discussion. In terms of its spectrum of activity, testing for nitrofuran generally doesn't occur in most clinical microlabs, but the good news is resistance to E. coli in the United States remains rare. So I think it's a good choice for E. coli, or if you happen to have a patient with Enterococcus faecalis, maybe they have a penicillin allergy, so they can't get amoxicillin, Phosphoomycin is a nice choice. About 10% of patients receiving Phosphoomycin develop diarrhea, so you just want to mention this to your patient and when they might need to present for medical care. The last drug we'll discuss is Metronidazol. It's an excellent anaerobic drug, but it's really limited to anaerobic bacteria, like Clostridioides difficile. At this time, the national guidelines suggest that metronidazole is considered an alternative treatment for oral vanc or oral fidaxomicin if they're not available. So the only time I would think about metronidazole for C. diff, if for some reason you're seeing someone with a confirmed diagnosis of C. diff in the telemedicine setting, would be if you can't prescribe oral vanc or fidaxomicin for some reason. And then notable adverse events: nausea, vomiting, diarrhea. For short courses, which is what you generally will prescribe in the outpatient setting, the likelihood of any kind of toxicity is very rare, less than 1%, and I mean neurologic toxicities. But for patients who are on this medicine for weeks, so sometimes people are put on it for weeks for C. diff, which is not how the drug should be used, or they might have had some anaerobic infection where they were put on it for months, like a brain abscess. About 20% of those patients do develop neurologic toxicities like neuropathies, confusion, even seizures. But fortunately for the indications you would use in the telemedicine setting, the likelihood of neurologic toxicities are extremely low. And personally, I usually don't stress this as an adverse event to patients if I know I'm only prescribing it for like 5 days, 7 days. And then, of course, there's a whole lot of other indications: peptic ulcer disease, diarrhea caused by giardia, trichomonas, sexually transmitted infections, and these will all be discussed in detail in future webinar. So to end the presentation, while antibiotics are necessary for many bacterial infections, the important thing to remember is antibiotics are associated with harm. They always have that potential. I always tell patients when I'm prescribing antibiotics what the potential harm could be. And when I choose not to prescribe antibiotics, I also discuss this with patients because it's important for them to understand that antibiotics are not benign, and there are some real risks that could be associated with them. And it always feels to me, whenever I see a patient with bad adverse events from an oral antibiotic in the outpatient setting, it seems more often than not that this patient just never needed the antibiotic in the first place. So we really have to sort of weigh the risk and benefit every time we present. We think about prescribing antibiotics to our patients virtually. So there's several slides that I'll just ask you to flip through right now that go through how to access the content on the webinar, how to obtain credits for CMEs, the references. Just because we're at the close to the end of the hour, I'm going to stop here just to see if there's any additional information anyone from the NORC team wants to provide, or if there's time for a question.